Good evening. I'm Dr. Parishek. I'm the orthopedic registrar working at Apollo OMR. So my case for today is regarding hereditary multiple exostoses with secondary hip arthritis. And yes, definitely a challenge for all. So I'll come back to that. What I mean by all. So just a small review into it. So just some path. So basically, HME is also called as diaphyseal eclasis, and it is an autosomal dominant disorder with basically characterized by multiple osteochondromas, mainly from the metaphyses. So this statistic which I've put up is most on the Western population. So surprisingly, we don't have a lot of studies in the Indian population about the prevalence of it. So this is 1 in 50,000 globally is what we've seen. Genetically, you have the EXT1 and T2 gene mutations and abnormal heparin sulfate synthesis. So what do you mean by that is basically the endochondral ossification of bones is affected, and meaning that it is overthrowing bone, and what you form multiple osteochondromas in that process. So coming to the common orthopedic manifestations which we see, so you can have like your limb deformities, like your limb length discrepancies. Obviously, because of it, your range of movements are also affected because of the deformities. And in the process of you having a deformity, you can also have nearby soft tissue compression and causing a nerve compression. And yes, definitely with time, the degenerative arthritis at a much earlier stage. So these are some of the X-rays which I've shown you. This is from the internet, not from our case specifically. So coming to our case specific, hip involvement, main deformities we see are mostly your coxa valga deformity. There's excessive femoral neck exostosis as well, mainly affecting the movement and rotations of the hip. Acetabular dysplasia, again, early onset arthritis, the risk of hip subluxation, and yes, like I said, early arthritis as well. So our case specifically was a 50-year-old gentleman who was a known case of HME for the last. He's been diagnosed since he was a child as well, and he was going about his life. But then over the last 1 year to 2 years, he suddenly presented with a progressive amount of hip pain. It was bilateral, but his hip pain was more on the right hip at the moment, where he mainly had difficulty even for something as basic as climbing up one flight of stairs. He was not able to do that. And yes, for also using the Indian toilet, so like squatting and sitting cross-legged on the floor. So he's actually, even though he was a known case of HME, he was a very physically active person, and like very involved in a lot of exercises and like yogas and stuff like that. So his presentation to us, because of this, he ended up having an antalgic gait, and he also had a reduced hip motion, globally restricted, but it was mainly really painful and restricted in external rotation and in flexion of the hip, in terminal flexion and external rotation. There was a limb shortening as well, with an internal rotated hip compared to the contralateral limb. So this was the pre-operative X-ray. So here we can see, yes, the left hip is also very
Parishek,
dysplastic, but then
once again, you can go a little bit slow. Okay. Otherwise,
sorry, sir. Yeah. So coming, so this is our preoperative X-ray. So here we can see that there's excessive exostosis mainly from the greater trochanteric region. You cannot even the joint line itself is like barely visible, even though we can delineate that is the joint line, and the acetabulum is very dysplastic as well. So there's also the proximal migration of the right hip compared to the left side. So yeah, comparing to the clinical presentation for the patient, rotation was decreased globally, and mainly difficulty in flexion and sitting cross-legged on the floor. So coming to the preoperative planning, so we decided to go ahead with a robotic total hip replacement for this patient for multiple reasons. Because one was, we need to calculate the native inclination of the cup which had to be placed. At the same time, for us to even get to the normal bone would be very difficult here, because you're dealing with very hypertrophied bone. So basically assessing the femoral canal anatomy, yes, your implant templating as well, and for the osteochondral removal, because based on the markers which you're going to be using in your robotic hip replacement, these were the main surgical challenges and the anesthetic challenges as well. So intraoperatively, so we went with the traditional, the hard hinge approach, and we had to do so we noticed that the femoral neck was really hypertrophied, and we were not able to understand where the actual neck had started, because when by the time we had reached the greater trochanter, so two challenges. One was the greater trochanter itself was so hypertrophy that we were not able to identify which part, where it was even starting, and which was normal and which was abnormal bone. And that was one thing. And second thing is, even when we had to place another one of the checkpoint pins for the on the ASIS, even that was difficult, in fact, even though we were using the robo. So but it definitely helped us a lot for us to calculate, compared to the contralateral hip, about the inclination as well as the version of the cup which we were doing. And again, the femoral stem preparation itself was definitely challenging. So yes, so why I said challenge for all, because so before we even started the surgery, the anesthetist had a real, like, something as basic as even establishing an IV line for him, or even getting an arterial line for him intra-op was really difficult because of his radial deformities. Sadly, I don't have the X-rays, but we were not even able to completely supinate his arm. So even for them to get a line, like, it was really difficult. And again, same thing in this case. Yeah, spinal, not so much. We don't really go all the time with the spinal anesthesia, but yes, that can also be a challenge to them as well, because of the interspinous landmarks being like difficult to identify. And surgically, like I said, the whole femoral anatomy is very distorted. The Your true femoral neck itself is like, the orientation is completely, like, it's a huge challenge because it's more internally rotated and it's way more hypertrophy. And acetabulum as well, because acetabulum, so at one point of time, you're basically, it's kind of like a, to some extent, a protrusion acetabular situation, because your head has migrated so much inside and so proximally that you don't know when you have reached the native base of the acetabulum. And yeah, so also the obstructing osteochondromas which get in the way. Intraoperatively, like I mentioned before, it is mainly the locating the true femoral canal and also identify the true neck shaft angle. Again, this was really helpful with the help of the rover comparing to the opposite limb, even though that was dysplastic as well, and also for attaining the true center of the acetabulum as well. Now, why the robo, my Mako was specifically very useful was because, yes, the anatomical landmarks, the optimal cup positioning, component positioning, including your for your femoral stem version as well, and also for yes, the 3D printing of it. So we were able to, even intra-op, when we had to nibble through a lot of the bone, like, we, because you're really dealing at a situation, because you don't know whether you have already crossed a greater chunk of the greater trochanter and you're digging into like normal bone now at this point. So the Mako had really helped with that. So this was the immediate post-operative X-ray. So when, like I said, when we were digging into it, like, the ASIs itself was also very difficult to identify for it, because that was also a little bit hypertrophied. So we had taken a little bit more of the greater trochanter than what was required, but uh, otherwise we were able to attain a good offset as well. Yes, definitely a little bit of a positive offset as well, higher offset as well as, but the inclination was really good, the version of it was really good, the stem was also, the position, it's central. um, so yes, coming to the most important part was the quality of life, because that's
So
the point
Parishek,
of this. Yes.
so do you
Sorry.
have your pre-operative surgical plan with the Mako?
So those videos, those pictures, actually, I just have
Okay,
this
okay.
alone. The plan.
Yeah,
This
yeah,
was
it's
the
okay. That's fine. Yeah.
this was
If you
the
don't
initial
have it, that's
plan.
fine.
Yeah.
No, no, this
The
is yeah.
inclination was.
Okay, go ahead.
Yes, sir. So, yeah, so the post-op protocol. So we had made him stand, I think around 6 to 8 hours after the procedure, the patient was made to stand. And then from POD1 onwards, the patient was mobilized. In fact, he was even able to climb stairs by POD1 evening. And then we did regular follow-up X-rays at 1, 3, 6, and 12 months. So this was the 3-month follow-up X-ray. So same way, the implant position is looking good. This was the 1-year follow-up, stable implant, no signs of any loosening or, yeah, any complications at the moment. So functional outcome, yes, the patient was really comfortable. He had, so the patient's, literally, actually the patient's complaint on POD2 was he had almost close to zero pain. So, which was very weird because we didn't expect, like, so the thing was his arthritis and the stiffness was that causing him that much amount of discomfort that he was able to bear the surgical pain, and he was mobilizing really comfortably, and he was actually pushing to walk without a walker within the first week itself. But yeah, I mean, obviously we had to take it a little bit slowly. So definitely very good functional recovery. The patient himself is really happy with it. So this was the a 1 year follow-up of the X-ray of the patient. Again, just reminding you, the right hip was operated. So you can see that, yeah, there's still a little bit of a lurch which is there, but like he's at least walking much more comfortably. So this is him walking in the park. So he's like, I mean, I'll show you some of the exercises he's doing right now, and yeah, it's really quite amazing the quality of life we've been able to achieve, and rather what we have been able to restore for the patient is really quite something. So these are some exercises. I mean, mind you, they are a little bit scary to look at, like considering he has a hip replacement done. But so he's just like getting along with all his activities. He's able to go about them. So quite honestly, we had to tell him to calm down a bit because he's just like it's like going a little overboard. But it's good. I mean, it's definitely something nice to see when your patients are like they're very comfortable. So again, see, he's able to plant the operatum on the floor more comfortably, and so that's helping a lot with his physio and generally his weight training and everything which he's been planning. So he had put this off for around 4 to 5 years because of the pain. So now he's been starting getting back into it in the last couple of months. So this is all 1 year. This was done on the Feb of last year, and yeah, so in conclusion, yeah, HME definitely can lead to early arthritis, and THR is the recommended, according to many studies as well. THR is the recommended method for an excellent amount of pain relief. But yes, careful planning is essential, and I personally think the robo specifically helped us a lot with the planning because it would have been difficult without that. And yes, good outcomes are definitely achievable. So literature review, yeah, the same thing. Like THR and HME has been shown to good outcomes. They do restore the hip biomechanics and improve the functional scores as well. So, but yes, definitely you need good pre-operative planning as well. And yeah, that's it. Thank you.
Can you go to the post of X-ray, Parishek?
Yes, sir. Yeah, the immediate post.
Questions, sir. The case is open for discussion.
You have a
The
photograph of
Parishek, the cup looks a little bit fair distance away from the teardrop. That's why I was asking if you had the pre-operative plan. So it doesn't. It looks slightly higher and quite lateral from the teardrop. Was this intentional or
No, we went according
what's
to the
that? I
robo
mean, generally, we try to
robotic.
get it really close to.
Hello.
Yes, sir. Yeah.
Yes, sir. So this was, yeah, so this actually we used based on the robo's guidance, because so it's not visible in this, but there was a part of the anterior column as well where it was devoid of bone. So we couldn't go, so we had to keep it a little bit at a higher level because we were not sure of how much bone extra was there. And the quality of bone as well was not too good. So we thought that according to the robo's
No,
calculation,
this is
that
not
this
a high
was
hip
a good.
center. The patient preoperatively doesn't have a high hip center. And the robot doesn't generally tell us where to put the cup. It is something that I think generally we have to decide. And I mean, the robot only helps us with the execution, if I'm right. So, I mean, I don't know if you planned it this way, but that's why I was asking for the pre-op planning CT. If you had shown that maybe there was bone loss, then yeah, that's a different scenario. But pre-op X-ray, I mean, it looked like more bone formation than bone loss, right?
So when the cup is lateralized, it can cause more wear, no, sir. It increases the abductor.
Yeah, somewhat superior cup is acceptable, but a superior and a lateral cup is generally considered, predisposing to loosening and wear in general. Yeah. So somewhat superior cup is okay. This lateralization is generally, something that most people wouldn't kind of think as good for long-term outcome.
If you compare
We
the
ask him to slow down.
offset, that is the composite offset to the opposite side, what is it? How does it measure?
So
I mean, like Arun
it is
said, the
it's
offset looks to
definitely
be more.
yeah, it is
That's
a higher offset.
okay,
It's definitely a higher offset compared to
The total offset is more because of or just the acetabular offset entirely, which is making the whole thing look more.
So I think in this X-ray, difficult to compare offset. It's quite externally rotated. So I think it's very difficult to make out the offset, especially the femoral offset on this X-ray. Do you have any X-ray where there is less external rotation? Again, this is again quite externally
Better.
rotated. Or I mean, it's very difficult to guess the offset from these X-rays.
I have a doubt. What was the workflow used? Was it like enhanced workflow or express?
Sorry, sir, I didn't get you.
Was the femur done with the robotic assistance or not?
No. Femur was not done in the robotic because femur we are not
Yeah,
able to identify the
Okay.
GT and LT. So it was done
Because Arun sir had
rehab.
a big talk on this bone impingement. I thought this case it was very much relevant to see
True,
the
but
virtual ROM.
Yeah,
that's
that's
what
fine. I mean, that's fine. Yeah. But I mean, the cup planning is what I'm a little bit, I'm surprised about. The cup, I think,
it could be more medialized, you see.
yeah, medialized and also maybe slightly inferior as well.
Thing is that if you're using the robot, then once the robot tells you where to place it,
No, sir, it doesn't tell us where to place it. It only, you can plan anywhere you want on the robot.
No,
I
sir.
think the
Actually,
robot doesn't tell us.
the robot doesn't do anything like that. We have to
discuss with
just
the
adjust
MPs
the
and
cup.
change it.
Yeah, we can change the cup positions, and
Robot can accurately place it wrongly.
the thing is, sometimes the registration and CT landmarks they may have it wrong, unless we check it every time before we start the case.
Very,
There
very
have,
unlikely, Arun. I don't think, I think think it has executed what was planned. Generally, that happens. Very, very rarely that you go off from where you planned. Unless the array has moved, it doesn't deviate. So this is mostly, because of all that abnormal bone, the planning, the Mako, they give a basic set plan. It is for us to see and adjust it according to where we need it.
Sir, another doubt, if they medialize the cup, there will be a problem with the offset in the stem, sir. So they might have planned like this because of that reason.
Yeah. I think this opposite looks pretty high offset.
Maybe offset.
And maybe the plan was to keep it lateral, match the offset. It's
Then
functionally
I
the
don't
patient.
Yeah, functionally the patient has done great. Yeah, but the thing is, offset. I don't think we hip center should be based on lateralizing the acetabular offset in an what to say
Okay.
intentionally. Nobody lateralizes the acetabular offset.
Taken. Point.
Yeah.
Yeah. Suppose if they have kept it the right center, would have managed with this stem, sir, or high offset stem? Or
Yeah, Striker has a 127 stem and a 132 stem. I don't know. I think this looks like the 132. I'm not sure though because
this
with the external
132, yeah.
rotation. Yeah, if you want a higher offset, you can use a 127 stem.
I can manage.
But here you already got a higher offset of the acetabulum. So obviously, if you have to, then you have to use a stem which is not a high offset. Otherwise, you'll have difficulty reducing it.
Correct.
Yeah, true.
So
Nitin
some
was asking
cases,
if it had been put in the right way. Maybe is there an option to increase the offset? Yes, there is. Yeah, that's what I was telling.
so some cases like osteopoikilosis, we have this very hard bony islands in the acetabulum or in the femoral medullary canal. So any tips on how to go about it, because when I put a reamer also, it's not like going very easily inside.
Actually, I had one. I had done one case. Subsequently, the similar case where I couldn't see the canal itself. Then I had to use a drill bit to just open it, and then use a flexible reamer one by one, like how we go for nailing, and then open the canal up. It was actually it was a surprise when I looked into it. I didn't. The patient didn't tell. It was the patient had some Pagets long time ago, but they didn't mention. It's quite difficult at that stage, but luckily we had some flexible reamers in the hospital at that time, and I was able to get the canal in.
I think I remember a presentation from Bose sir long time back, a case of osteopetrosis. Yeah, I think some of the principles were to have multiple stem options where you could ream and get a stem in. He had used Wagner cone because metaphyseal stems might be difficult to broach in those situations. So small conical stem is probably a very friendly device to use in those cases. And as Dr. Damodaran is saying, you have to open the canal somehow and then with reamers, and then try to get a ream only stem, which is generally a conical stem or a cylindrical stem.
The smallest one when striker I used for that, I was able to achieve that much, because beyond that I was getting scared to open it further because I might fracture it. So as long as I got this little one inside, the smaller stem, then I just stopped. I will present it next time, that one, because it's completely, the canal was completely chock-a-block like a marble. And I had to use a smaller size drill bit and then larger size drill bit to get it little bit started. And then I slowly used a flexible reamer and then got the canal in.
Sir, thanks, sir. Thanks for the nice case.
Thank you, Parishek. Thank you.
Rather
you,
than the case, the anesthesia complications, everything, it's new to us.
Yeah,
actually.
this case they had to use a pediatric intubation tube while giving GA, because they couldn't find the normal adult didn't go through because of a short neck. That was also anesthetically, it was very challenging because they couldn't get a spinal.
Thanks, sir. Sir,